Hello, and in this video, we are going to review the content from week 3 on birth defects and prenatal diagnosis, as well as newborn screening. Here are your objectives for week 3. You will be reading chapters 3 and 4. You have 3 different videos to watch about topics that are covered in this week's content, along with watching this content video. You have the reading quiz for week 3 and the week 3 online discussion. As of 2017, there has been more than 24,000 genetic disorders that have been identified, and testing is available for over 5,000 of these disorders. Individuals from certain ethnic backgrounds may have a higher risk of carrying specific gene mutations. This chart from our textbook, is table 3.1, and this is a table that details disorders with increased carrier frequencies in particular ethnic groups. So as humans with genes and chromosomes and DNA, we can carry different types of disorders. We can carry them and they can be expressed, and we can carry them and they can just be not expressed, be a recessive gene for us. So this table details an ethnic groups and specific disorders that they are estimated to be greater carrier for. So if we look here, the ethnic group Mediterranean, this beta disorder, they have a higher estimated carrier frequency, whereas among European and North Americans, the disorder of cystic fibrosis, there's an estimated 1 in 25 people are carriers of this disorder. Now, that does not mean that 1 in 25 people have cystic fibrosis that are Caucasian, but they also may just be a carrier of it. So something that is very common now is carrier screenings, and these are tests that can be done on parents, and they can identify if you are a carrier for a specific type of identified disorder. If these are a recessive disorder and both parents are carriers of this recessive disorder, then there is a higher likelihood that their children will have this disorder. However, if one parent has a recessive disorder and the other parent does not, that child will not be affected. It is important to screen for and understand family history when you are carrying a child. Screening is recommended to all women regardless of age. There are also psychological implications of prenatal testing. For example, when I was pregnant with my son Walter, we did the carrier screening. And through that screening, I was identified as being a carrier for a very rare genetic disorder that affects the body's process of cholesterol. Now, this is a recessive disorder, so we had my husband screened as well, and he is not a carrier for this. So that means that our children would never be affected by this disorder. But if my husband was a carrier for it, then there would be a likelihood of 1 in 4 chances that any of our children would have this disorder. So there is the psychological implications of this testing is the stress and anxiety that can come with being identified as being a carrier for specific types of disorders. There's a lot of different types of screenings that occur during pregnancies. Again, if you remember from the previous weeks, pregnancies are tracked very closely because if something can be identified sooner, there's a greater benefit from early intervention. The first one mentioned in our textbook is an ultrasound, and you can identify fetal and structural anomalies in up to 3% of all pregnancies, and approximately half of all major anomalies can be detected. An ultrasound in the first trimester usually occurs pretty early on, and that is used to make sure that the fetus is developing appropriately from the very beginning. Maternal serum screening is a fancy way to say testing urine and blood of the mother. So in these tests, they're looking for HCG and this PAPPA, which are the hormones that tell us that you are carrying a child. These can identify Down syndrome, trisomy 13, and trisomy 18. And it can also identify adverse pregnancy outcomes. So again, in the first trimester, the very beginning of pregnancy, your blood and urine are tested almost immediately at your very first appointment. Fetal echocardiograms are a tool that can be used to evaluate fetuses with an increased risk for congenital heart disease. So if you have a family history of heart issues, you can your doctor might recommend that an echocardiogram can be done, and that is what is up here in this picture. So the practitioner uses a transducer, which is like a form of an ultrasound, so that they can get a really good close look at the baby's heart. Another type of screening is cell-free DNA or NIPT screening. And this is that tool that I was talking about that helped identify me as a carrier for a disorder. And this is a primary screening tool, and it's not diagnostic. So it can just give us information. It cannot diagnose information. This can be done as early as 9 weeks in pregnancy, and it uses a blood sample from the mother. Continuing on, in the first trimester, they can also do CVS sampling, which takes a small biopsy of the outermost membrane surrounding an embryo. This would be used for if you needed to analyze chromosomes, if you needed to look closely at the enzymes, molecular DNA analysis, and chromosome microarray analysis. It's not diagnostic for neural tube defects, and it's the safest invasive prenatal diagnostic procedure prior to the 14th week of gestation. So this would be if there was a concern if your baby was going to have a more serious disability. This might be something a doctor would recommend. And they're taking that biopsy of this membrane that surrounds the embryo. And then they're sending it off for testing and analysis. Moving into the second trimester, the baby is getting bigger, so some of our screening techniques will change. There is an ultrasound that happens. Generally, there are several ultrasounds that happen in a healthy, typical pregnancy. But in the second trimester, a big one is the 20-week anatomy scan, which occurs between 18 and 22 weeks of gestation. This is a real-time ultrasound. So what's happening is there's an ultrasound going on, and the practitioner is looking for the baby to do specific things. So taking breath, doing specific things, moving their limbs, the way their body is moving. There's all these different things that they're specifically looking for. And in this, they can identify more than 70% of major structural anomalies. They're measuring a lot of bones, and they're looking very, very closely at the baby. In second trimester maternal serum screening, it's continuously checking urine and blood of the mother, making sure that they're hitting correct markers and indicators that there are different ways that they can identify abnormalities. Amniocentesis is a procedure that can happen between 15 to 20 weeks gestation, and that's what's going on in this picture right here. They take amniotic fluid directly as a sample to look for abnormal levels of biochemical compounds. This can tell us if there is going to be a neural tube defect, so if there's going to be an issue with the spine, the brainstem, and they can also identify if there's going to be any abdominal wall defects. An MRI is possible as long as it is further along than 17 weeks gestation. There's no known maternal or fetal risk. They can look very closely at the brain, the airways, the lungs, and if for pregnancies where there is low or no amniotic fluid, this is a good option because the amniotic fluid that's surrounding the baby is what the ultrasound needs to make that picture. So if there's something going on in the pregnancy and there's no or low amniotic fluid, an MRI is a great option. They can also do a fetal echocardiography during the second trimester. Again, this is going to be for infants where they're worried about the heart. This is a targeted ultrasound that's performed between 18 to 22 weeks of gestation, and 10 to 15% of infants with a congenital heart defect have an underlying chromosomal abnormality and can often have additional anomalies and intellectual disabilities. They can also take diagnostic testing of fetal cells for any genetic disorder for which a familial DNA mutation has been identified. So if you have a family history of a specific mutation, they can test those fetal cells for any diagnostic information. Genetic counseling is a way that you can learn more about an abnormality and make informed decisions about your baby and for your families. They pay close attention to certain environmental exposures to decrease a risk of birth defects. So if during a pregnancy, a baby is identified with going to be having a certain type of abnormality, so maybe some testing that was found from carrier testing from the parents, or maybe they found something on the ultrasound and they are able to identify that this baby is going to have cystic fibrosis. They would your doctor would refer you to a genetic counselor who would work with you on learning more about cystic fibrosis, how you can make good decisions for your family, for your baby, how to get you connected with good health professionals and medical teams for your child. Alternative reproduction choices that are discussed in our book are pre-implantation genetic diagnosis. So if there is a risk of having a child with a known genetic disorder and parents wish to conceive an unaffected child biologically, or they want to avoid having to consider pregnancy termination. So this might be something that is used if both parents are carriers for a specific disorder and they do not want to have a child with this disorder. Then they can use genetic diagnosis, usually through processes like IVF, to ensure that they can have a child biologically that will not have the disorder. There's two of these assistive technologies, IVF, which is in vitro fertilization, and intracytoplasmic sperm injection. So both of these are done in a laboratory, and they're a way to provide an alternative reproductive choice. In summary, for Chapter 3, maternal health issues can be addressed throughout prenatal planning. So if there is a concern, carrier screening can be done even before pregnancy. So you can have that knowledge before you even consider getting pregnant. Accurate dating leads to early prenatal care and access for early screening. Decisions from screening and diagnostic testing are very complex and ideally addressed with a genetic counselor. Imaging studies may be needed to clarify abnormal prenatal findings. Those imaging studies are those things like additional ultrasounds, MRIs, and any echocardiograms. Any early diagnosis of fetal abnormalities gives parents time to make very important decisions, how they're going to support their child, what their medical future looks like, any healthcare issues. And assisted reproductive technology is also an important option for families. Chapter 4 moves into newborn screening. So now the baby is here, and we need to make sure that we take care of the baby. So a screener test separates those who are at increased risk for a condition from those who are at a lower risk. As of 2017, there are 34 disorders recommended on a uniform screening panel and another 26 secondary targets. Disorders on the screening panel are on a screening panel because they are serious, identifiable, and treatable. And treatable does not mean that a disorder can be cured. It just means that there's a clear support plan for this specific disorder. And newborn screenings are done through infant blood samples and then through point of care studies, which is nurses or doctors observing a baby. And those point of care studies are looking at hearing test and congenital heart disease. So right over here in this chart, they take a hearing screen, they do a heel stick, which is that blood sample, and then they'll check the baby's pulse oxygen level. Some of the measures that they're looking for: hearing loss. We want to identify all children with permanent hearing loss by age 3 months. We can initiate appropriate interventions by age 6 months. We need to establish a medical home for infants with permanent hearing loss, and it's a way to track data and quality metrics for public health initiatives. So, if we can identify a hearing loss earlier, we can provide interventions earlier. Critical congenital heart disease is the most common congenital malformation, and that is something that newborns are screened for. They're screened for endocrine disorders, which are issues with growth hormones and not usually due to a genetic defect. And they're also screened for infectious diseases like HIV and toxoplasmosis. Newborns are also screened for immune disorders. So if a baby has issues with their immune system, the term bubble baby comes from babies that are born with an immune disorder that causes them to have no immune system. So they are placed in this protective bubble that keeps the germs from the outside world out. These immune disorders can also be done prenatally through a diagnosis. And then they also look at metabolic disorders. These are impairments of the body chemistry at the cellular level. Amino acid disorders such as PKU and fatty acid disorders. This is a picture of what a newborn screening the blood sample looks like. They poke the baby's heel and then they get that blood sampled, and then that is sent off to the lab. Blood samples are usually need to be done at least 24 hours after birth. So they are not taking your baby's blood sample immediately upon birth. It needs to be at least 24 hours after birth and after a baby has eaten enough breast milk or formula, because some of the disorders that it screens for, the metabolic ones and the endocrine ones, the body needs to be responding to some input of food in order for those to be identified. So the blood samples have to be taken at least 24 hours after birth and after a baby has eaten enough food. Each state decides how to handle a positive screening result and how to follow up. So usually that includes if there is a positive screening result, the information on your screening will be sent to your child's pediatrician or doctor, and they will be notified of that, and then the family will also be notified, and then they'll do some definitive testing about the specific disorder, and then as needed, they'll be referred to a specialist or genetic counselor. If there is a confirmed disease, you will be referred to a medical specialist with expertise in that area. There will be ongoing care and intervention. They'll be checking for a reoccurrence risk if this is a disease that can continue to come back and continue to affect the baby. And I want you to think about the impact on the families. All of this stuff is happening when a baby is so little, just born. And so you will definitely encounter students that have diseases and disorders that have been identified immediately upon birth, maybe even before. The families are carrying this emotional impact from the beginning of a child's life. And by the time they get to you, maybe in kindergarten or middle school or high school, this family has already been through a lot. And so there's a lot of weight and stress and anxiety that can be placed on families. So as you think about this when you go into the classroom in your field experience, and then down the road when you start teaching and then you get your own job, the way you interact with families is extremely important. And coming from a place of empathy, even if you haven't been through something like this with your own child, you can be empathetic to all that families have to go through if they have a child with a more intense disability. So it's important that newborn screening is done, because if there's unidentified and untreated disorders, this can lead to significant morbidity. It can be very serious for children. It can even lead to death. Children identified by a newborn screening had fewer developmental and health problems and functioned better comparing to children diagnosed at a later age. Again, early intervention is extremely important in our health and in school. So if we can identify children with specific needs, health needs early in life, there's a greater likelihood of success and more positive experience. Screening can fail for many, many, many reasons. A lot of them are often that the testing was obtained too early, before 24 hours, and before a baby has had enough breast milk or formula. Screening can also fail with our babies that are born premature or in the NICU. That's the neonatal intensive care unit. Those are our babies that need a lot of support. Screening can fail for those babies as well, simply because they are early and they're little. In summary, screening tests are important tools that are used to help define increased risk for significant medical and genetic conditions. These tests can be used for mass screenings of newborns, prenatal screening, and targeted screening of at-risk populations and ethnic groups. That is all for our week 3 content. If you have any specific questions about anything, please reach out to me. Do not forget to do your reading quiz and your discussion. Thank you.